I see it's 2 o'clock, so we'll get started. Welcome everyone to our second session, Partners in Pain, Yorkton Community Events. Very happy to see all you folks joining us again today. A few new faces and some folks that joined us last week, so thanks very much for being here. Once again, I'm going to start with a land acknowledgement. These are always really important to me. Like I said, a lot of the work that I do, relationship building is important, and that's what a land acknowledgement represents for me. So as we gather today, we're acknowledging that we are on treaty land. I'm coming, of course, from Treaty 6 territory, traditional territory of the Cree, Saulteaux, Stoney, Nakota, and Dakota people. Our folks joining from Yorkton are joining from Treaty 4 territory, traditional territory of the Nihawa, Cree, Saulteaux, Dakota, Lakota, and Nakota, and formerly Blackfoot people. So once again, we dedicate our efforts to working together in a spirit of reconciliation and collaboration. I also wanted to review for our new folks and as a reminder how this great event came to be again. So this Partners in Pain workshop came about as a result of the Improving Pain in Saskatchewan collaborative research project, which some of you folks have participated in. What this project is doing is giving folks living with pain a voice by bringing people together to share information and plan action to improve how pain is managed in the province. The team started by interviewing people who live with chronic pain, the people who support them, healthcare providers, and decision makers. Already interviewed, as of last week, was 140, and I'm sure that number has gone up since then. So folks living in Yorkton, in Regina, and also in Saskatoon as well. The discussions with folks living in Yorkton led to the planning and development of this series of workshops. And it's really a chance for folks to learn more about their pain, hear about people's experiences living with pain, try out some new activities to help you manage your pain, and also to bring us all together, it's a great sense of community, definitely. At the end of the workshop, we will show you the list of people involved in the workshop planning. Many of us are participating today as well, and also the organizations that funded these workshops and the Improving Pain in Saskatchewan research project. So today's theme is on the treatment of chronic pain. So of course, with our last session, we did that introduction and chronic pain 101. And so today we're going to chat about actually treating with chronic pain. And we've got a number of speakers here today to speak to that. First of all, we're going to start off with our healthcare professionals, and I'm going to invite Hilary Stamatinos to speak first. So Hilary's a clinical pharmacist and a certified diabetes educator that specializes in geriatric pharmacy. She's the store operator at Laux Pharmacy in Yorkton, Saskatchewan, where they provide care to Yorkton and the surrounding area nursing homes. They host diabetes education sessions, and they practice in many specialty areas such as travel health, sport, and medical brace fittings. They provide ostomy supplies and intensive medication reviews. Most importantly for me with Laux is they are very close to Scoops, the ice cream shop, which was something I took advantage of when I was in Yorkton. So with that, I will invite Hilary to take over and talk to us about managing chronic pain from a pharmacist perspective.
Thanks, Kelly. Yeah, that being next to Scoops is one of my favorite things too. Definitely take advantage of that for lunch, maybe a little too often. So as Kelly mentioned, my name's Hilary. I'm doing this presentation from home today, and my puppy is here with me. So if there's any background barking or animal noises, I apologize in advance, but she's getting pretty good, so she should be okay. So I really want to touch on during this talk the 4 Ps of pain management. So those are pharmacological, psychological, physical, and preventative. And the 4 Ps, they really make up the pillar of chronic pain management. So you don't want to rely just on one pillar, because then you sort of have a wobbly tower. So throughout this whole thing, I'm going to mostly be talking about the pharmacological pillar just because that's my area, but just keep in mind it's not the only one, and if that's the only one you're using, you're going to have a wobbly tower. So as far as medications go, though, I don't mean to downplay it. It's a strong pillar. We've got a lot in our arsenal. There's a lot of different types of pain medications that work on different pathways and also different types of pain. But because of that, because there's so many choices, so many different types of pain, sometimes it is possible to not get the right medication for us on the very first trial. And honestly, maybe even not on the second trial either. But before we think about switching a medication too quickly and saying, you know, that one didn't work for us, it's really important to make sure that we give it an adequate duration. Otherwise, we just really didn't give it a fair shot to see if it worked or not. I see this a lot in my practice. You know, sometimes people will try something for, say, a week or so. But you really need about a 4 to 6 week trial period for most chronic pain medications. And there's confusion, you know, because for an acute injury like a headache, you might take a Tylenol. It's going to work within hours, within minutes. But chronic pain is just so much more complex. The drugs really need time to build up into the system at an adequate dosage to get to the full effect. So you got to really you know, wait out that period before you give it the thumbs up or the thumbs down. Again, too, you also want to look at your dose, you know, make sure that you get up to an appropriate target dose. And sometimes I find some confusion where, as I'm sure a lot of you will know, you often can't start at that target dose. So you're really waiting till you can titrate up slowly to that target dose. And then once you're at that target, that's when your 4 to 6 week trial is really going to start. It's not going to start from the minute that you started taking that medication. So that's another thing too. We say 4 to 6 weeks, but really it could end up being even longer than that just because it'll take you a bit to get up to there. Another really important component of treating chronic medications that I like to discuss with my patients is that it's so important to set realistic expectations and goals. The goal of a chronic pain medication, unfortunately, is often just to give you enough pain relief to move, to participate in activities, and to improve sleep, basically to improve your quality of life, but not necessarily to get us down to zero pain. We just don't have that magic pill that can do that yet. And I pray and I hope, I know we're going to get there one day, but unfortunately that day isn't today. So really for chronic pain, the best we can do with medication right now is often just looking at a 30 to 50% decrease in pain from baseline. Anything more than that, we say, you know, that was an effective trial. So again, we're unfortunately just not being able to completely get rid of that pain, just making it so that we can enjoy life as much as we possibly can with reduced pain. So because of this, and because we know that we're looking at a 30 to 50% decrease being good, it's really, really good to start using something like a pain scale so that you can start keeping track of where your pain's at. You know, that way you're going to know if the medication's working for you or not. So the easiest one, and the one that I like to use a lot, is the 1 to 10 scale. It's basically 0 being no pain, 10 being the worst pain that you've ever had in your life. And then you just kind of want to plot where you're at on average with that pain scale. And what that does is it lets you really effectively communicate to your healthcare team where you're at by using numbers. Because it's hard for us when a patient might say, you know, my pain was bad before, now it's maybe a little bit better. We get so much more information if a patient can tell us, you know, when I started this medication, my pain was about an 8 out of 10. Now it's a 4 out of 10. You know, suddenly we're having something that we can measure. And as I was saying before, a 30% reduction is really what we're looking for. So on the 1 to 10 scale, that's going to be a drop of about 3 points. So what you want to do, get your pain journal, use it as much as you can, just plot, you know, when I wake up, say I'm a 4 out of 10, I go for my morning walk, maybe I creep up to say a 6 out of 10 or so. Before bed, you know, maybe you're at a 7 out of 10. And what we can do is we can take all those data points and we can put it into an average. And then once we get that average, we can say, you know what, say you were an 8 out of 10 before you started this medication. You properly waited till you titrated up, which was great. You got to target dose. You waited 4 to 6 weeks for it to get to that full effect. And after that 4 to 6 weeks, maybe you're at a 4 out of 10 right now. So that 8 out of 10 to a 4 out of 10, that's a 40% drop. That's, you know, so we're going to say that was an effective medication for you. That one's working for you. But say you did all that, you started at an 8 out of 10, you did everything right, you did your 4 to 6 weeks, you waited till it titrated up before you started that. And now all of a sudden you were at an 8 out of 10, your average only really dropped to a 7 out of 10. That's no good. You know, that medication probably isn't working for you. That was only a 10% decrease. So your benefits and risks aren't really outweighing there. So then as a team, we know, hey, 8 out of 10 to 7 out of 10, we can do better than that. We're either going to end up looking at changing your medication or putting in one of those other pillars, doing something else. The next P is psychological. And I like to touch on this a little bit, even though it's not my area, just because it's so important. And I feel like it's the most underlooked pillar. So psychological, that's going to include things like mindfulness, social support, stress management, spirituality, relaxation, things like that. And I really don't want you guys to underestimate the power of the psychological component. Really, I challenge you to try to build that one up just as high as you have your pharmacological pillar. And I really think that you'll find a really positive impact from that. The next two pillars are physical and preventative. And Sumita is going to do an amazing job telling you guys about those. So I don't want to dig into her time at all for those. But if I could leave you with one piece of advice to remember that everybody needs an individualized approach, and try to incorporate all of the pillars into your individualized approach. What worked for your neighbor, it might not work for you. So don't get frustrated, be easy on yourself, but at the same time, make sure that you're a very good advocate for yourself in the healthcare system. And if something isn't working for you, let your team know. But yeah, thank you so much, guys, for listening. I really appreciate it. If you have any questions ever about any of your medications, doors always open. Again, we're next to Scoops. Pop in, get an ice cream before you come. And any of the pharmacists there and myself would be so happy to answer any of your questions. Thank you.
Thank you so much, Hillary. That was excellent. And just reiterate something that kind of came up last week with the 4 Ps. So that was an excellent segue for Sumita. So Sumita Hintz is a physiotherapist, a graduate of the master's program at the U of S and owner of Prairie View Physiotherapy in Yorkton. She indicates that she is British Canadian, but grew up in multiple countries, particularly in Asia. Wow, that's awesome. And has made Yorkton her home since 2015. Her passion as a physiotherapist is helping people gain back quality of life following injuries or other issues that have affected them negatively in both their physical and mental well-being. Sumita, it's all yours.
All right. Thanks, Hillary. That was really great. And I'm just going to keep going with the 4 Ps there. So if we talk about physical, so there's 2 main categories for the physical pillar. There's the active and the passive. So if we talk about passive, that's things like massage therapy, as in like the hands-on part of massage therapy, acupuncture, chiropractic treatments, hands-on techniques in physiotherapy for loosening stiff joints or releasing tight muscles. So that is kind of what we would call passive. There's something in the passive section that I think maybe a lot of people are not totally aware of that I would like to touch on. It's called dry needling or IMS. So what this technique is it uses an acupuncture needle, but it's a different technique than acupuncture. It's a muscle release technique that works really well for chronically tight muscles that have a hard time relaxing despite other interventions like hands-on myofascial or massage release, chiropractic or acupuncture. So it's really good for the stubborn stuff. And essentially, what happens in this situation was when the muscle is stuck in a semi-contracted position, the needle that we use, the acupuncture needle that we use, we target the trigger point or the tight area in the muscle or the knot, as we like to call it sometimes. And that causes a maximal contraction of the muscle fibers in that area, which then in turn causes a maximal relaxation. So you can see how we're kind of bypassing the brain and the nerve system, and we're doing a mechanical stimulus to make the muscle relax. Because the problem with chronic pain often is that there's a sensitivity of the nervous system or the nerves in the brain. And what's happening is the signal is just coming like crazy, and then the muscle is staying contracted and not allowing itself to relax. So if we bypass that system and we cause a mechanical stimulus to the muscle and can cause it to relax, then we actually get a better effect. So that's maybe something that a lot of people have not necessarily been informed about. So I just kind of wanted to kind of touch on that. There is research behind it. Research shows that when they test the inflammatory markers of a muscle, so all the kind of nasty stuff that you don't like sticking around in your muscles, when they test that before a treatment and after a treatment of dry needling, those markers are down. So it does actually clear out some of those yucky inflammatory products. So what I've found in my practice that this is useful for is particularly chronic tension and symptoms in the neck and shoulders. So those people with like those chronic myofascial headaches, things like that. Low back and hips. Yeah, lots of low back hip stuff, right? And then also acute issues that have a tendency to then fall into chronic categories. So things like tennis elbows, stuff like that. So I found that this technique is a passive technique that does really help with specifically muscle tension issues. Now, the more important one, I should say, is active. I have to say that, I'm a physio, right? Anyway, so the active side of the physical pillar, things like stretches, things like exercise. Now, I'm not talking like crazy exercise. I'm talking specifically tailored to your issues and injuries or your chronic pain as your individualized exercise plan. Being active is as simple as going for walks or walking your dog, aquasize, home projects, vacuuming, cleaning house, stuff like that's all active, right? So all of that stuff is actually considered being active. So it's not a big scary word, and it's not like going to a gym and like pumping metal or whatever they call it, right? It's actually having quality of life and being able to participate in the things that you want to participate in. So if you have a physiotherapist or even a massage therapist or exercise therapist who's working with you, they're going to help guide you in the active stuff. So Hillary kind of touched on the psychological as well. And I just kind of want to add one thing in there. Active exercise, when it is done to a moderate level of effort, actually helps us feel better, because what it does is it releases what we call endorphins in your body. Well, what's that? An endorphin is a feel-good hormone, basically, and they are naturally produced by your body, and it's not something that you take in a tablet. It's something that your body produces, and it's your body's way of rewarding you for staying active. So actually, exercise is medicine, because it's your own body's way of helping that pain modulation. So everyone's level of moderate activity is a little bit different. For some people, it might just be a brisk walk, right? You can get your heart pumping a little bit with a brisk walk. That's all you need to do. Again, you don't have to go to a gym. You don't have to do these, maybe go to areas where you're like, I don't really feel comfortable because there's lots of people around and I don't like people watching me and stuff like that. You don't have to put yourself in an awkward situation at all. It's something that you enjoy, doing it to the point where you feel like your heart rate is coming up a little bit. That's all that it takes. And when we have these endorphins released, we feel good. And then when we feel good, we feel like we've accomplished something. Well, that does like miracles to your mental status, right? So being active is actually a part of your psychological pillar too. All right, and then the last one, preventative. So when we think of preventative things, typically we think of things like wearing a knee brace for sports if you've had a previous knee issue, but also think of it in this way. So let's say you're seeing a physiotherapist for help with a chronic pain situation. So if you're seeing a physio, they'll give you the knowledge of what movements are safe and what movements or activities are likely going to aggravate things for you. So knowing what to avoid is half the battle, because sometimes people come in and they're like, I don't know what happened. And then you kind of talk around a bit, and then you go, oh, I think I know what is the movement that is aggravating you. So stop doing that movement. And then you find that, oh, actually, I'm coping with the symptoms a whole lot better, and I'm actually being able to participate in things as long as I pay attention to not doing that movement. But everything else is actually good to do. So then it kind of takes some of the fear away from being active and being able to participate in things if you know what specifically to avoid. So I guess I just want to quickly, do I have time?
I might cut you off there, Sumita, just to see if any folks have any questions right now. But certainly you're joining us again for the activity after we chat with Jackie. So if you want to tack anything onto that time, then if we have a chance.
Okay, sounds good.
And I see that Wendy has raised her hand. Wendy, do you have a question? Do you want to unmute yourself?
Okay, I was just wanted to ask Sumita, who do you like? Obviously, you do the dry needling. I'm assuming who would you recommend to go to search out for this? Just anyone who does acupuncture, or is there something specific you want to make sure, some specific training you want to make sure they have before you book in with them?
Yes, so acupuncture is a different different category than dry needling or IMS. So it would be dry needling or IMS. So you can either, I know that there are, I think Acupuncture Canada, but that's more for acupuncturists. I think there is a website where you can actually see everyone in Canada, I believe, who is a registered IMS or dry needling therapist, as long as they've given consent to put their name up. Now, I'm going to have to actually find that website because I'm not exactly sure all the whatever. So I'll have to find that for you. But yeah, an acupuncturist is not the same as a dry needling specialist. Typically, dry needling or IMS are physiotherapists. Yeah, sometimes doctors, but more physiotherapists, I would say. I think
so.
Susan, think that too, right?
So one kind of a question in addition to that, you mentioned it's best for like kind of stubborn problems. So if you have an injury and it's, maybe flaring up at certain times, or it seems to be kind of part of your anatomy that will speak to you every now and again if you do a certain thing, that's what you're meaning with a stubborn injury, not something that maybe happened recent and is still more acute.
Yeah, so dry needling can be used for both acute and chronic, but I found it to be most effective with chronic issues, particularly muscle tension issues. Yeah.
Very nice. Thank you so much. I appreciate that.
No worries.
Thanks for the question, Wendy. There was another question, Sumita, from Carol. She's wondering if dry needling will help with carpal tunnel.
So depending on what is causing the carpal tunnel, so if it's more inflammation based, probably not. If it's got a myofascial component, maybe. that would help as well. So it really depends where the carpal tunnel is coming from. If it's coming from kind of like chronic tension all the way from, so a lot of people don't know that carpal tunnel can actually not necessarily be caused by the wrist. It can actually be coming from the shoulder and even in the elbow. So if that is the case, then potentially yes, because there's lots of muscles that cross the shoulder and the elbow, right? If those are tight and they're pressing on the nerve and causing the carpal tunnel, then potentially, yes, it could assist. However, if it's, let's say someone's pregnant and they've got carpal tunnel and it's because of a fluid retention issue, probably not. So it kind of depends where that carpal tunnel is coming from. Does that make sense?
Thank you. I also saw a comment about folks can go to the Saskatchewan College of Physical Therapists, which is the licensing body, and therapists who do dry needling are often listed. So once again, we'll be sending out information after the session today with the evaluation. So we can put some of these links, and Sumita, if you have any other links to add, we can pass those along to folks. I also see a question for Susan, or for Hillary from Susan. In the interest of time, I'm going to table that one. As a pharmacist myself, I know that that takes a bit to answer that one, but we'll table it. I'm going to move on to our person with lived experience, but certainly hopefully we'll have a little bit of time at the end to address some of these questions. If not, maybe we could put something together in the information to send out to folks afterwards. We can work together on that. Okay, so next we have Jackie Murphy, who is our person with lived experience joining with us. I'm just seeing if Jackie is there.
Yes, I unmuted myself.
Okay, hi, Jackie. So Jackie lives in Yorkton with her husband. She has 2 adult children on their own, working and attending university. Jackie is a social worker and manages a team at Mental Health and Addiction Services in the Yorkton and Regina rural area. Oh, such important work, Jackie. Jackie lives with osteoarthritis, a disease that has severely affected her health recently. Thank you so much, Jackie, for joining us. And I'm wondering if you could start by just telling us a little bit about your pain journey.
Okay, sure. Well, my journey starts with the curse of family genetics. So on my mom's side of the family, there is a strong history of osteoarthritis. Sure enough, that turned out to be my journey as well. Back in 2010, I think it's the first time I remember starting to experience fairly significant pain. I was attending the gym on a regular basis for a few years and doing really well, but developed pain in my knee and hip to the point that I couldn't actually walk up the stairs anymore to use the gym. And so I started to kind of slow down physically a bit, manage with rest. And then in 2012, we sold our acreage and we moved into Yorkton. That's when I next remember significant pain, of course, from all the physical activity with doing a move. But that's, I think, when I started talking to my family doctor and my nurse practitioner and starting to look initially at medications and physiotherapy for managing and coping. By 2016, my pain and the arthritis was so significant, it was affecting my mobility. And I remember we were on a family trip to the mountains with the kids, and we would pull up to a tourist attraction. We couldn't park just necessarily anywhere in the parking lot. We had to drop me off first at the doors where we were going. And then, the kids would park and we'd go inside. I remember on that trip, the kids and my husband pleading with me to go to the doctor and to get something done, ask to see a surgeon. And unfortunately, I didn't listen to them. I think I went for another x-ray, another MRI, but I didn't really myself, I think, take it as seriously as I needed to. I continued to lose mobility. I continued to have sleep problems. It definitely started to affect my image of myself physically. My self-esteem, my ability to do my job was affected. Pain on your brain all the time makes it really hard to think and to be able to concentrate and work well. So finally, it was, I think, about 2 years ago in February of 2019, I went to my nurse practitioner and I said, please, it's time for a referral to a surgeon. And they did x-rays at that point, which showed very severe osteoarthritis. My family doctor said it was kind of the worst case he had seen in a long time. And at that point, then I was able to wait on a waiting list for about 19 months, but eventually had surgery then back in November to have a full hip replacement. But it's certainly been a very tough go over those years. And I will be destined for more issues. Certainly my knee and my other hip have mild and moderate osteoarthritis started. So it's been a really, really challenging 10 years, 12 years in my life. There's been, I know, conversation today about medications, and certainly that played a role for me. Early on, I was on some anti-inflammatory medications and a stomach medication to go with that. Eventually, I was on to a softer narcotic painkiller, and that worked well for a while, but unfortunately, a person builds some resistance to that or dependence on it, and they switched me to a bit stronger medication at that point. 2 weeks after surgery, though, completely off all of my pain medications, and so grateful for that. Physiotherapy, as Sumita was talking about, was very crucial for me. I started physiotherapy before I went to surgery, and the next day after surgery in the hospital, they take you up to the physio department to start your exercises. And I remember the physiotherapist saying that he could tell I had been doing some physiotherapy before surgery. I think it went a long ways to helping recovery after surgery. And of course, then I had some physiotherapy after surgery. When I first went off work, which would be about a year and a half ago now, I guess, July of 2019, I took a huge crash mentally, emotionally speaking. I developed fairly significant depression and a good dose of anxiety and a lot of worry about what was ahead for me in terms of waiting for surgery and my future after that. So I talked to my family doctor, and he referred me into a psychiatrist in Regina, who I still have appointments with every month and a half, 2 months. It's one of the collateral issues with chronic pain is the effect it has on your mental health. Your ability to cope just on a general day is really compromised when you're also dealing with depression and anxiety and trying to cope that way as well. When I had to quit work, I think I experienced quite an identity crisis in my life. I've always worked. We grew up on a farm. We worked hard, went to school, got a job, worked hard. And not being able to work really impacted my sense of who I was and my purpose, what was really meaningful for me, not to discount my family and friends in my community, but I took a real hit there when I couldn't work anymore, for that period of time. And I think that contributed to my mental health as well. Tracy, who's here with us today, had recommended I attend the user therapy online program. And it's an internet cognitive behavioral 6-week program, 7-week program. It's interesting because by career, I teach cognitive behavioral therapy to folks that suffer from depression and anxiety. Taking the course was really meaningful for me just in managing my situation at that time last fall. Provided really good coping skills, ways of thinking differently, realizing that I needed to pace myself better, the importance of setting a goal for myself each day, and having some structure in my days. So I thank Tracy, for that recommendation. That certainly was a very important program that supported me through this journey as well. I've been really blessed to have a strong family, friends, even my work community was so supportive for me throughout all of this. And I'm really fortunate that way. I appreciate every day the support system that I've had. I know that's not always the case for a lot of people. And I know COVID has had such an effect on people as well, just with, not being able to socialize and being a little more isolated and distanced from people. I just feel really blessed that I've had a strong support system. There was some conversation a bit earlier about relaxation and mindfulness. And I took up that idea really quickly once I went off work. And I just went to YouTube and would Google relaxation exercises, mindfulness exercises. And again, really helpful for me in the evenings before bedtime, just to kind of settle down that stress reaction you have all day from living in pain. There's a physical stress reaction every day, and there's kind of that mental health stress reaction. And relaxation, mindfulness went a long ways just to help me be a little more settled during the day, and certainly to be able to have a bit better sleep. So going forward, I manage very carefully. I think something that really hit me was weight gain. When I couldn't work anymore and I couldn't go for walks anymore, and you're on the depressed side, so things look good to eat. I had gained some weight while I was off work. I'm really fortunate now with mobility that I've started to exercise. I go to the Gallagher Center to walk, and now that the weather is better, I go walking here in our community as well in Yorkton. That's sure gone a long ways to improving my self-esteem and helping me physically feel better. I do some step aerobics at home, just on the TV. There's a program, video on demand that you can watch. And so I do that about every third or fourth day. I take a rest though, because I know I can only go so far, and I'll start to have flare-ups on my knee and my other hip. But exercises and staying physically as mobile as you can, I agree, has been really important to wellness and preserving what physical health I had, and keeping me going afterwards. I'm back to work now. So I feel really fortunate in that a lot of people who've been off work as long as I have been, statistically, the chances of going back to work drop a fair bit. And I'm fortunate that I have been able to go back to work. I must say, though, that my confidence, I didn't expect this, but my confidence took a hit after the last 2 years of suffering with severe pain, and the effect it has on your cognitive abilities and your, as I said, self-image, self-esteem. So I'm in my 4th week now back to work, and confidence is coming, but I wasn't expecting that I would feel a lack of such confidence that I did when I first went back to work. So that's kind of the challenge I face right now, and staying on top of my health physically and keeping in regular contact. I was fortunate I have a strong medical team with me as well, a nurse practitioner, family doctor, who have been wonderful. And I keep in touch as I need there as well. So that's kind of, I guess, the Reader's Digest version of my experience living with chronic pain and managing, and kind of my journey through to where I am today.
Thank you, Jackie. That is, I was really, what impacted me most was hearing the impact that pain has had on your life, on your relationships, on your work, just that wide net that it casts, and not just on physical health, but emotional health. Yeah. Just the extent, the effect that it has. I'm wondering if you could just kind of speak a little bit. The other thing that really stood out for me is how you have managed it, and your strength and your adversity, and what you have done to really manage your pain, which is phenomenal and to be applauded. And I just was wondering if you could speak a little bit about your motivation, like what keeps you going on those days where you just can't get out of bed, on those days, like what do you find is your motivation?
To be honest, I'm in my mid-50s now, which should never have happened. I still feel, like I should be 20 something. But what keeps me going and pushes me each day is the acknowledgement, the recognition that I'm on the other side of the hill. And I want to have some quality of life. I want to have some experiences. I want to be able to do some things and have stories to tell. So getting up and pushing and going every day, pushing through the pain, pushing through the depression, anxiety, is important to me, because I want to have the second half of my life, or, what's left of my time, to be good quality time. This whole journey made me realize my mortality, and how important it is for me going forward that I have some sense of quality of life. And if all that means is that I can cook lunch that day for my husband, and that's the extent of what I can get done that day, that meant a lot to me. So just, I think, recognizing not to take each day for granted, not to take time for granted, that make the most of what you have, and even though it's just little things you can do, it's so important to push forward and keep doing that.
Stories to tell. That really resonates me, because one of the things that I love most about my work is hearing people's stories. So thank you for sharing yours. And
Yeah.
it just kind of also speaks to the research project that kind of brought about this event, is hearing people's stories, because it is your story that's going to make us able to help others and to help manage pain better in our province. So thanks again, Jackie.
Thank you for having me.
I'm wondering if there are any questions for Jackie. I see a comment from Tracy. Jackie, your spirit of perseverance, optimism, and sense of humor are very encouraging. Thanks for the courage to tell your story. Thanks,
I'll be
Tracy.
heading out to the lake pretty soon, Tracy, to Good Spirit Lake, so we must connect.
I can be there in 3 hours, ladies. Any other questions for Jackie? All right. Once again, thank you, Jackie. With that, I think we'll move on to our activity. So we have Sumita joining us again to lead us through a gentle movement activity.
Okay. So I decided to kind of focus on kind of general muscle stretches for the neck and the low back. I thought those were kind of two areas that a lot of people have issues with. So I thought maybe we'd focus on those. There is, don't worry about having to write everything down, because I did send a handout to be emailed to everyone. So you don't have to try and make massive jot notes. What I want you to try and do is maybe do these with me and see what they feel like. Okay. All right. So the first one here. So I chose three for the neck area. These three, they kind of get the main culprit muscles that kind of cause headaches and shoulder pain up into the upper back, where the neck and the back connect. So the first one is you're going to bring your nose down towards your armpit on one side. Okay. So just kind of coming down like that. Now, if that feels fine and does not feel like a stretch at all, take the hand that you're leaning away from. So if I'm gonna sit on my right hand, I'm gonna sit on it. This will hold my shoulder down so that it can't come up when I move my head over. Now do the same thing. So nose down to your opposite armpit. You should feel a little bit more of a stretch. If you don't, and you're like, yeah, still not good enough, Sumita, then do the same thing. Take your other hand, put it on top of your head, and pull into that position. You should not have pain with these stretches, okay? So a big problem that we see is people go, oh, my stretches just make me hurt more. And then I say, well, does it pull or does it hurt? And they say, well, it hurts. Okay, well, don't go into hurt. You just go into pull, not into hurt. Okay, does that make sense? So with all of these stretches, you should feel a stretch or a pull, but not a hurt. So that is the first one. Okay, the second one is it's a little bit trickier. You're going to pretend like you're going to bring that same ear down to your armpit. So what it ends up happening being is a little bit forward, rotate away, and look up. That way you'll have your ear coming towards your armpit on your opposite side. You should feel the stretch in here. Okay. If you're not feeling the stretch in there, you're probably not forward enough. So make sure you kind of tip forward, then you rotate and bring your ear as if it's going to your armpit. Okay. If you don't feel enough of a stretch with that, you're going to sit on that same right hand and do the same movement there. Again, if you don't feel a stretch there, you can always add a bit of overpressure as well. So you can always modify stretches to be more or less depending on how tight the muscle is and what it feels like. Okay. The next one, I'm leaving the easiest one for last, is if you're in good posture. So what I mean by that is your ear is in line with your shoulder. Okay, so a lot of people will kind of, this is an exaggeration, but a lot of people will be like here, right? We want you here. So once you're in that position, then you just tip over to the side as if you're bringing your ear to touch the top of your shoulder. Does that make sense? So it's a straight side bend, basically. You should feel it here. Is everyone feeling it in the right spot? Yeah. And again, all the same things apply. If you don't feel a good stretch, you're going to sit on your right hand and tip over to your left. If you still don't feel a stretch, you can add a little bit of pressure there. Okay. Any questions about those guys? No? Okay. All right. So I thought as well that we would do a couple for lumbar spine or low back, because lots of people have low back issues. So the first one here is a little bit trickier to do. You might not be able to do this right where you are right now. I'm gonna see. Can everyone see my treatment table? So this stretch is called a child's pose. Now, I will show you some modifications to this because not everyone can get in this position. Okay. So ideally, you want to be in this position here. Okay. Now, not everyone can bend their knees that far, put weight on their knees, etc., right? So I'm going to show you a couple of modifications for that. I'm just trying to arrange my camera here. So another way that you can do this is you can actually kneel on the ground instead. Put something soft under your knees. So this is still going to be a problem for people who have issues kneeling, but I'll show you a different one again. So kneeling on the ground. So now this is not being a problem for the hips because the hips don't have to come all the way down and the knees don't have to bend so far, right? So in this position, then you would do your stretch from here. Does that make sense? Now, if that still doesn't work for you, you can actually do this in standing. And if you have a countertop here, you can actually lean on the countertop and your legs are straight. So you're not having to kneel on knees, not having to bend hips and knees too far. So there are several modifications in how to do that one. That one I actually really like because not only does it get low back, but there's a muscle called the latissimus dorsi, which is a nice Latin term. But anyway, the muscle comes from the low back, comes all the way up, inserts into the arm. So if you're having issues anywhere along here, that guy's probably gonna do good for you. Okay. The next one here is, now I will qualify this one and say that you have to do this one gently, okay? So how this one works is lying on your back like this, and you're just gonna let your knees gently fall to one side. Should not be painful, okay? If it is painful, don't do it. And then let your knees fall to the other side nice and gently. Now, if this feels good and you're coming to here and you're like, ouch, it hurts here. Next time, don't go to that far. You're just going to go to where it doesn't hurt. Okay, so again, it's the same thing. You don't want pain, you just want pull. If you have a hard time pulling your legs back up again, what you can do is put a belt around your legs and help with the belt to pull back up again. So just like so. So if you're coming over here and you're like, my issue is that it hurts when I pull my legs back up, use the belt, pull yourself back up again with your arms rather than your legs. Does that make sense? All right. The next one can be done in either lying down or sitting. So I'll show you in sitting first, and then I'll show you in lying down. I'm just going to change this angle here. So a lot of low back stuff also radiates into the hips. Am I not correct? Yes. All right. So the two kind of main groups of muscles in the back of the hip can be stretched like so. So if you can do this, this is harder to do in sitting. So I'll show you in lying down, which is a modification. You bring, let's say, your right ankle and put it on top of your left knee. Now, if you already feel a stretch there, you want to make sure that you're in good posture and you're not slouching forward. If you already feel a stretch there in the buttock area, that's great. If you don't, you're going to apply a bit of pressure on the knee to push it out a little bit, or down a little bit, I should say. Okay. The second part of this stretch, which gets the second main muscle that is a culprit in the back of the hip, is pulling your knee up and towards your opposite shoulder. Okay. If this is a problem for you because of either mobility in the hips or the knees, you can change this up to do it lying down. Okay. So you go here, and from there, and then give pressure there, and give pressure this way. This is a much easier position because it doesn't require as much hip mobility. So as far as these stretches go, like if you are working with a physio or a massage therapist who also gives exercises, or a chiropractor who gives exercises, instead of you just being handed a sheet, make sure you do this in their office so that if there are any issues, they can troubleshoot it for you and get you in a position that is actually going to work for you. Because there's no point in you going home with stuff that you can't do, right? And that is kind of what I had. How are we doing?
We're right at 3 p.m. Sumita.
Okay.
Perfect timing. Thank you so much for that. And certainly if you can share those with folks, I appreciate all those modifications because some of those did have a bit of a pull. So thanks so much for that, Sumita. With that, we are at 3 p.m. and that brings our second Partners in Pain community event to a close. Once again, thank you to all of our speakers. Thank you to everyone. We will be sending out the email with links and other information from our healthcare providers. Don't forget to join us next week. So next Wednesday, the 24th, same time, we're going to be talking about resources. So lots of great information about how to actually access resources in our province, in your community in Yorkton, as well as within the province. So stay tuned for that and have a great week, everyone. Thanks again for being here. Happy St. Patrick's Day.